Now, moving on to our third section, then we will briefly discussing what about the neurological injury which may be associated with acute trauma or the fractures of thoracolumbar spine. In this section, we're discussing what are the different type of lesions, what is a complete and incomplete spinal cord injury, what are the different anatomic levels, that is the cervical or thoracic spine, which can lead to what type of injury mechanisms, and then briefly discussing what about the incomplete spinal cord injury, whether this is it an anterior cord syndrome or a posterior cord syndrome, central cord syndrome, or is it a Brown C cord syndrome. So neurological injuries or neural injuries can be defined in form of level, whether they occur at the cervical spine, at the thoracic spine, or the lumbar spine. What is important is that if it occurs at the level of C4, this usually results in a quadriplegia or tetraplegia. Why? Because the spinal brachial plexus actually starts from C5 onwards, so there is loss of almost all the brachial plexus, lumbosacral plexus, leading to massive quadriplegia, and all the muscles of the limbs may be not functional. If it's a C6 injury, somewhat there is sparing, because C6 injury means the C6 nerve is actually exiting above the level of C6 vertebra. Therefore, this means the C5 and C6 are intact, which would mean that C5 is actually supplying the biceps. This means the elbow flexion would be intact, and brachioradialis would be intact as well. This would mean that if it's a C6 vertebra fracture, the patient would be able to flex his elbow as well as extend his wrist. So this is very important. Then probably the wrist flexion as well as the elbow extension, that C7 may be absent. So then we may be able to manage, because some muscles are functioning, some may not be functioning. Now if it's a T6 injury, brachial plexus is already exited out, so the upper limb would be very much safe. Even if it's a complete T6 injury, problem would be at the level of the lower limb, because there will be complete loss of lumbosacral plexus, so there will be complete paralysis of the lower limbs, leading to paraplegia. But what is important is, because usually thoracic spine has morely autonomic exits in terms of the ganglia, the sympathetic chains which are actually coming out. Therefore, whether it's L1 or T6 usually mostly results in the form of paraplegia, and motor loss is very much similar, but there may be associated autonomic reflexes which will be intact if it's the loss at the level of L1. What is important is to know that whether this displaced structure may damage the cord or nerve roots. The cervical lesion, I told you, usually cause quadriplegia, while thoracolumbar region causes paraplegia. This damage may be partial or complete. If it's complete, this would loss of all the sensory as well as the motor functions below the level of spinal cord. So lesion could be classified in form of neuropraxia, or it could be cone transaction, or it could be root transaction. Now, to understand what is neuropraxia, is actually actually loss of nerve function, which is usually temporary. What happens is there is a motor paralysis which is flaccid, because there is a lower motor neuron lesion. It may be associated with burning paresthesia, sensory loss, and visceral paralysis below the level of the cord lesion. But the good part is it has an excellent prognosis, and usually the function returns within few weeks to months, and recovery begins and soon becomes, a patient usually progresses to full recovery. But if it's a cord transaction, this means actually the whole complete cord has actually transacted at a certain level. Now this will result in a motor paralysis, sensory loss, as well as visceral paralysis below the level of lesion. All sensations as well as motor function would be lost. Cord will be in some kind of a shock as well. Initially, post-traumatically, there is always associated spinal shock. And if there is no return of actually anal tone and anal wink is not going on, or is not negative, then probably a patient has suffered from usually the complete spinal cord injury. But sometimes within the first 40 hours, patient may be in kind of a spinal shock, and there will be mimics a complete spinal cord injury as well. Sometimes the patient may take up to 2 weeks to come out of the spinal shock. So what is important is to know whether there's a complete cord transaction or it is a complete spinal shock. Within 4 weeks of injury, usually tendon reflexes return and flaccid paralysis becomes spastic. This is actually from lower motor neuron lesion becomes an upper motor neuron lesion. What is the root transaction? As you know, then if we are discussing, when we discuss or when we see the anatomy of the spinal cord, there is actually a dorsal root ganglion, which is actually containing the cell bodies of all the sensory nerve supply. And this is where from this the root, there is a dorsal root as well as a ventral root, which is actually forming a single root later on, and then there is an increased expansion of this neural tissue called as dorsal root ganglion. This could lead, the root transaction can occur at this level, and this could lead to complete sensory losses. Now, if this this may be associated with motor loss as well. If all the fibers which are exiting and entering into spinal cord were also containing the motor fibers as well. This because the somatic nerves has to exit through this and eventually go towards the viscera or the muscles. So this is associated with motor paralysis, sensory loss, and visceral paralysis, and in distribution of the damaged roots only. And root transaction recovery may occur, but may be resulting in a complete cord of spinal cord injury. And residual motor paralysis remains permanently flaccid. Sometimes the sensory sensations do come back to some extent, but not complete return of sensation as well. And usually the motor recovery is almost incomplete and remains so for the life. Now, the other way of describing the different spinal cord lesion is through the anatomical level. As I told you, whether it is a cervical spine, and then again when we are talking about cervical spine, it's an upper cervical spine, lower cervical spine. Upper cervical spine means above the level of C4. Now this would result in a quadriplegia with loss of almost all the muscles upper as well as lower limb. Lower cervical spine injury at the level of C7, C8, this may result in some amount of function of the upper limb, especially of the biceps, brachioradialis, and forearm muscles as well. If it's between T1 and T10, upper limb would be intact and all the muscles of the upper limb would be definitely normal, but there will be loss of sensations from the at T4 level is at the level of the navel, and from that means usually at the sternoclavicle junction below that level there will be loss of sensation as well as motor paralysis. If it's below 10, usually this means it's below the level of the waist and all these muscles usually resulting in a paraplegia. Now there's another term called as incomplete spinal cord injury. If it's not complete, what is incomplete? This could be leading to a central cord syndrome, which affects this area of the cord. It could be anterior cord, which is affecting this area, or it could be posterior cord, which affects only this area, or it could be the Brown Sea cord syndrome, which actually affects the hemisection of the spinal cord. Well, then this could be lead to that when there is incomplete injury, there will be some sensations will be present and some will be lost. So by assessing this, what type of sensations are present and what are lost, we can easily assess whether it's anterior, central, or posterior, or Brown Sea cord syndrome. What is important to know before I move on to central cord and anterior cord syndrome, this area contains the dorsal column tract, which is usually lost in the posterior cord syndrome. And dorsal column tract is mainly responsible for a sense of touch, deep pressure, proprioception, and vibration. Usually this area is mainly the motor containing corticospinal tract, and this is mainly the bulk of somatic afferents which are actually going through the spinal cord, which are going to the muscle, and the loss of the corticospinal tract leads to motor paralysis. Now this area is usually also sensory, and this is mainly contains the anterior and lateral spinal thalamic tract, which is responsible for carrying out a sensation of pain and temperature. So when the central cord usually syndrome happens, this could be due to 2-3 mechanisms. There is actually cervical degeneration in old age. Cervical ligaments may also loosen up. There is degeneration of cervical spine with posterior ossified formation, and sudden hyperextension injury can lead to this type of a central cord syndrome. And what happens is there is loss of complete motor paralysis due to loss of corticospinal tract, which is initially flaccid weakness followed by lower motor neuron paralysis of upper limb, and upper motor neuron paralysis of the lower limb. What is important over here is that upper limbs are affected more than compared to lower limbs. And why? Because corticospinal tract is actually exiting and the upper limb fibers are lying over here more towards the center, and the lower limb fibers are lying over here towards more the periphery. So because of this is a central cord syndrome. It affects the upper limb fibers more as compared to the lower limb fibers. So sometimes even some part of the lower limb fibers are spared as well, but mostly it involves a complete paralysis and affects the upper limb more as compared to the lower limbs. With intact perineal sensation, which means this is definitely usually the sensory involvement is sometimes not complete as well, because you can appreciate the dorsal column tract and spinal thalamic tract are usually intact, but there may be associated some degree of damage to them as well. Now coming to the anterior cord syndrome. Anterior cord syndrome is due to the thrombosis or thromboembolic phenomena of anterior vertebral artery, which is lying in the anterior fissure over here. If that gets blocked, this whole anterior spinal cord may become ischemic and leading to anterior cord syndrome. What happens is, as you can appreciate, the corticospinal tract is involved, spinal thalamic tract is involved, only the dorsal column tract remains intact. So the patient loses the pain and temperature sensation. Patient loses there is motor paralysis because there is loss of corticospinal tract, but as the dorsal column tract is intact, so there is a deep pressure, vibration, and proprioception senses are actually intact. Now the other incomplete spinal cord injury may include the Brown-Séquard cord syndrome. It is classically termed as hemisection of the spinal cord. That is, actually cord is split into the half. Now it's important, if this whole is lost on this side, there will be ipsilateral loss of corticospinal tract. This means there will be ipsilateral paralysis of the muscles. Similarly, ipsilateral loss of the dorsal column tract as well. That means the ipsilateral loss of sensation of deep pressure, vibration, and proprioception. But as we know that spinal thalamic actually tract decussates and goes towards the opposite side, so there will be contralateral loss of the pain and temperature sensation. Then there could be associated posterior cord syndrome as well, in which only this is lost, that is the dorsal column tract. So therefore the deep pressure, proprioception, and vibration sense is lost. Pain and temperature senses are intact. There is no motor paralysis. But if it's Brown-Séquard cord syndrome, as I told you, there is contralateral pain and temperature loss, ipsilateral loss of the deep pressure, proprioception, and vibration, as well as motor paralysis. And the most common injury is usually when there is actually a stab in the back. Sometimes the knife penetrates such a way that there's actually leading to hemisection of the spinal cord. This can lead to Brown-Séquard cord syndrome. Now coming to the management of traumatic paraplegia and quadriplegia. If it is, suppose, a cervical spine complete injury and quadriplegia, or there is thoracolumbar injury leading to paraplegia, how to manage this? Now skin can be managed through there is definitely increased chances of pressure sores. Regular 2-hourly log rolling is required. Pressure care and pressure reducing mattresses are available, and patient care education is needed, that you need to prevent the pressure sores. And the next thing is to look up after the bowel and the bladder. Bladder and bowel training as early as possible. Usually they are associated with autonomic bladder. Why? Because once it fills up, the detrusor muscle contracts, and actually this leads to urination. But this is really associated with high volume of residual urine after emptying of the bladder. There may require special investigations as well as special maneuvers, such as use of Foley's or use of external catheters as well, just to make sure that the patient does not wet his or her bed. Similarly, the carer also has to be educated whether the patient will have less control over the bowel and bladder and how to manage that as well. Now coming to the muscle and joint. Suppose a paralyzed muscle, if not treated, they usually get into a severe flexion contracture, leading to deformity, and eventually the joint also become immobilized, eventually further leading to kind of a severe form of a joint contractures as well, and which may be very difficult to treat at times. Sometimes they can be, when the joints are okay, then you can simply treat it with splints as well as physiotherapy, and calipers may be required as well. But upper limbs are usually trained until the patient uses crutches and the wheelchair. And then tenotomies may be required as well. When we are saying tenotomy, means using drilling a hole in the bone and putting the tendon in such a way that it becomes more functional. Tendon transverse, suppose if it's a cervical cord injury and it's at the level of C6, this means C5 and C6 nerve roots are intact. Patient has intact biceps as well as deltoid as well as brachioradialis. Now that means it's below the level of C6 is a lower cervical cord injury. That means patient may be able to use limited number of functioning muscles in the arm to provide a primitive pinch mechanisms. When we're dealing with this kind of a patient, the patient already has a quadriplegia, so hand function becomes of paramount importance. And with hand function, there are two functions of which are highly important. One is the pinch function. The patient is able to pinch with his thumb and index finger, and the second is the grip function. So this grip means using muscles and making the wrist in extension so that the patient can lift something up. If that can be restored, and with elbow flexion is already intact because the patient has injury below the level of C6 and deltoid is intact, and patient can abduct the shoulder, almost whole of the function can be restored. But if the injury is above the level of C4, where the abductors are also paralyzed, the bicep is also paralyzed, and all the intrinsic and flexors of the forearm paralyzed, then it's really become difficult to, because there is actually no muscle to transfer to. But supposing it's a C6 injury, this means the C6 nerve root exited above the level of C6 vertebra, C5, C6 are intact, which means the bicep brachii function is intact, and patient would be able to flex his arm and deltoid as well, and use the deltoid to abduct his shoulder. So if only deltoid and bicep are working, that is C5, C6, what do? We do posterior deltoid to the tricep transverse, because C7 is not intact and tricep is not functioning. Therefore, elbow flexion is already there. Elbow extension can be achieved by transferring deltoid to the triceps. Therefore, the triceps becomes functional and elbow extension can be achieved. Therefore, enable the patient to orient his or her hand in the space. Why? Because when we are taking in food, this is important. If the patient can pinch and take his elbow into flexion as well as extension, this means the patient can take his or her arm towards the food, pick it up and put it in his or her mouth. So it actually provides a very important function, and the job of the carer becomes very easy. Now, if there is C6 is also intact, that's the brachioradialis is also intact, then what we know that we have a wrist extension available. For a pinch function, you need to have extension at the wrist joint as well as a flexion of the FPL or flexor pollicis longus. But if FPL is not intact, there are two possibilities. One is that primitive thumb pinch can be achieved by Moberg procedure, which is actually FPL tenodesis. If FPL tenodesis is done in such a way that there's actually the flexion of the distal phalanx of the thumb, therefore some amount of the flexion is achieved by FPL tenodesis or Moberg procedure, other can be achieved by the wrist. And by use of these, usually the intrinsic muscles are usually in the contracted phase, so the patient can have some kind of a primitive pinch in this form, which can be achieved in this situation. If extensor carpi radius longus and brevis are also intact, if the injury is so level at below the level of C7, this is very helpful. This would mean that this triceps would be intact as well, and ECRL and ECRB would be intact as well. Then one of them can be transferred in the FPL to provide an active thumb flexion. So as you know that the ECRL and ECRB are actually originated from the common extensor origin, and the surgery can be done at the elbow. The ECRL and ECRB, one of them can be rerouted towards the FPL, which is originated from the common flexor origin. Therefore, thumb flexion can be achieved, and intrinsic functions would definitely be not present as there is no C8 and T1, but patient will have intrinsic contractures of the hand along with the wrist extension, and if you can achieve flexion of the thumb, that would provide the pinch along with the wrist extension, and elbow flexion extension is already occurring. So therefore, patient can have the two primitive functions of the hand can be used to at least he or she can eat, or he or she can take care of his or her hygiene, which is of the utmost important, and then the job of the carer actually reduces to minimum. In this section, we briefly discussed what are the associated neurological injuries which may be present along with the spinal cord trauma. This could be a complete spinal cord injury, which may present at the cervical level, which may lead to quadriplegia, or this could present at thoracolumbar level, which may lead to paraplegia. What is important is that there may be, along with the complete injury, there may be associated partial injuries as well. And partial injuries are defined by whether they are affecting the dorsal column tract, whether they affect the corticospinal tract, or whether they affect the spinal thalamic tract or not. There could be a central cord syndrome. This could be an anterior cord syndrome as well, or simply the posterior cord syndrome, or simply leading to hemisection of the spinal cord called as the Brown-Séquard cord syndrome. They have different their own individual signs symptoms. In central cord syndrome, there's actually corticospinal tract which gets affected more, and upper limb is affected more than compared to the lower limb. There may be a partial loss of sensation due to some degree of damage to the spinal thalamic as well as dorsal column tract. In anterior cord syndrome, the main problem is with thrombosis of anterior vertebral artery, leading to the loss of corticospinal tract and motor paralysis, as well as the loss of spinal thalamic tract, leading to loss of pain and temperature sensation. In Brown-Séquard syndrome, there is actually a hemisection of the spinal cord, which may be secondary to trauma or injury, penetrating injury to the spinal cord. This leads to the ipsilateral loss of motor function that due to damaged corticospinal tract, ipsilateral loss of deep pressure, proprioception and vibration due to damaged dorsal column tract, and contralateral loss of pain and temperature because spinal thalamic tract decussates toward the opposite side and actually supplying bringing sensation from the opposite side of the body. Thank you very much. Keep watching sqadia.com.